So hello guys, welcome back to another video, and I hope you liked the previous case. In this we are going to our further case based MCQ discussion. So without wasting any time, back to the case. So in this case we have a 54-year-old man who has suffered from a cardiac arrest, right, in the ER after having a myocardial infarction. He is resuscitated and is placed in the ICU for further monitoring. Then after that, he has been extubated because his mental status improved, and he was discharged after 1 month. Now he has been referred to a neurology department because of sudden jerks upon gait initiation, and there is no evidence of any seizures. So what are these jerks? So to get any clue about these jerks, let's look at this. This man has got an hypoxic insult to his brain, right? And he has recovered from the hypoxic insult, right? After that, he has presented to us with jerks, probably myoclonic jerks, right? So we are basically discussing a case of post hypoxic myoclonus, right? I will tell you about the DD of this case. So this is probably a case of post hypoxic myoclonus. This question actually tests about your knowledge of the medications used in post hypoxic myoclonus. Now, what are the medications mostly? Will it be carbidopa, levodopa? No. Why? Because this is not a case of Parkinson's disease, and carbidopa or levodopa are not going to help in any way in a case of myoclonic jerks. Carbamazepine, definitely no, because there is no evidence of any partial seizures. So we are not going to treat this patient with carbamazepine. Now the question arises whether we'll go for this clonazepam, right? Now clonazepam is a GABAergic drug. Now studies on post-hypoxic myoclonus are very limited. Only just 150 cases have been published. It's a very rare entity, but whatever cases have been published, they have seen that the GABA is decreased, right? So GABA is an inhibitory neurotransmitter. Decrease in the inhibition will lead to this myoclonus, right? So basically we are trying to increase the GABAergic transmission. Why not clozapine? Definitely we are not going for any antipsychotic. We don't believe this to be a psychotic disorder. And carbidopa definitely you'll use for his cardiac causes, but definitely you will not use it for his myoclonus. So this is not the answer. So the correct answer here is clonazepam, right? Let's discuss it further. So this syndrome is otherwise known as the Lance-Adams syndrome, and it is characterized by action myoclonus. As in this case, as you can see, he developed the myoclonus while initiation of the gait, so that is known as action myoclonus, and it occurs after a hypoxic injury, maybe from recovery from a cardiac arrest or from a recovery from any drug overdose, or due to general anesthesia leading to respiratory depression, or an asthmatic patient who recovers from the respiratory arrest. So in these situations where there is a recovery after a hypoxic injury, you call it a case of Lance-Adams syndrome, and gait is usually affected. So definitely if it involves the legs, there can be positive or negative myoclonus, which can result in falls, which I will discuss. And medications that work on the GABA receptor, such as this clonazepam, are typically used for this treatment. We can also use levetiracetam, we can use sodium valproate, zonisamide, or sodium oxybate, because they all potentiate the GABA activity in the brain. Definitely, I talked about this that he may require a beta blocker, but this is not going to reduce his myoclonus. Carbamazepine, there is no history of any partial seizures. Carbidopa, levodopa, not. Clozapine is an atypical antipsychotic used to treat hallucinations and psychosis, and we are not going to use this because this patient is not a case of any psychosis or hallucination. So let's discuss further about this Lance Adams. So this syndrome is characterized by a generalized action myoclonus as we described previously, and it is following hypoxia due to respiratory arrest, probably due to asthma or any general anesthetic or cardiac arrest like in this case, or drug overdose. And the patient is usually not comatose, right? He was previously comatose followed by a recovery of coma. That is the sequence of coma, recovery, followed by myoclonus. This sequence is very crucial. Why? Because if myoclonus develops concomitantly with coma, we call it myoclonic status. Okay, that is a very different entity and it's got a very poor prognosis. Very poor prognosis. But this, on the other hand, this Lance Adams has got a very good prognosis, and as I discussed previously, it has got positive and negative myoclonus leading to false. And experimental studies, especially in rats, have described the role of serotonin and its metabolites, that is decreased amount of 5-hydroxyindole acetic acid in the CSF. So there have been experiments on this rats, especially usually rat experiments, where they have seen that 5-HT1B or 5-HT2A receptors are actually being, you know, if there are agonists which stimulates these receptors, they have some role, but human studies are actually lacking. Basically, you are going for these GABAergic drugs like valproate, right? Or in this case, clonazepam. Levetiracetam has to it has got a role, but it's not as conclusive as these two drugs. These drugs have got 50% efficacy. Vigabatrin and gabapentin, even though they are GABAergic drug, this is the catch. They are not promising in the clinical trials. Don't know why, but they are not really promising in the human trials which have been undertaken for this purpose. And this Lance Adams syndrome improves with time. So with time, the myoclonus will improve. It's a chronic myoclonus. One of the causes of chronic myoclonus, you can remember it as Lance Adams syndrome, right? Now, let's discuss about the DD. The most important DD I told you is the myoclonic status, and how to differentiate the level of consciousness. Like in this case, he's a conscious guy, so this probably goes in favor of Lance Adams. If he was a comatose guy and within 20 to 24 hours of the coma, definitely I would be talking about a case of myoclonic status. It is generalized multifocal. Here also it is generalized, but it is an action myoclonus. Like in this case, it occurred at the gate initiation, right? And the prognosis here is very poor. Here it has got a very normal intelligence, and here you get neuronal necrosis. You get neuronal necrosis here. There is ischemic injury, but here there is only hypoxia, no infarction, right? So that's the major difference between the two. Now, the experimental studies have actually demonstrated that some there have been two published reports, I think two in China and some 40 reports where they have actually imaged the brain. So on the metabolic imaging of the brain, what they have found out that there is increased activity in these raphe and these pontine tegmental areas. Also, there is decreased glucose uptake in these frontal areas. So we are still working on the pathogenesis. It's not completely clear as to why this occurs, but probably decreased functioning of this frontal lobe and this pontine tegmental area is responsible for the myoclonus. But yes, always and always it's open for research. Still studies are going on, but it is an entity which has got a very good prognosis that you have to remember. Thank you very much. I will be updating you subsequently on another case. And if you like this video, please give a thumbs up on that button, and thank you very much for your patient hearing.